So our next speaker is Dr. Marielia Gerena. She's an academic radiologist with a specialization in abdominal and pelvic imaging. She currently serves as the section chief of body imaging at Westchester Medical Center, where her research focuses on MRI and CT techniques for evaluating liver and abdominal pathology. Her work has made significant contributions to imaging techniques used for prostate and other pelvic cancers. Her talk is titled Advances in Prostate Imaging, and it will explore new imaging technologies and their applications in prostate cancer diagnosis and treatment planning. So welcome.
Thank you. Okay. Well, thank you for that introduction, Jonathan. Again, my name is Marielia Gerena, and I am a radiologist here with Westchester Medical Center. I'm talking today about prostate MRI. It sounds like a very niche technology and a very, very small specialty, but it has done tremendous advances in how we view prostate cancer. I have no disclosures. So I will briefly talk about prostate cancer, then I would jump into clinical considerations, some technical specification. I'll try to keep it light, going over normal anatomy and benign findings, as well as what do we do and how do we do it in terms of reporting, how we stage it on imaging, and also briefly some emerging techniques. Am I able to, yeah, okay, great. Oh, perfect. Yes, I did. Awesome.
There's a laser if you press that middle button there.
This one. Okay. Prostate cancer. How common is it? The American Cancer Society estimates that in 2024, there will be approximately 299,000 new cases diagnosed. Of these, 35,000 patients will die of the disease. The risk of getting prostate cancer is about 1 in 8. They will be diagnosed at some point in their lifetime. These diagnoses are more common in older men, where 6 out of 10 diagnoses are in individuals over 65, and it's much less common, much more rare on patients that are under 40 years old. It is also the second leading cause of cancer deaths in American men after lung cancer. And prostate cancer death declined by half from 1993 to 2013, likely due to the early detection and advances in therapy. The silver lining is that while this is a very serious disease, most men do not die of it. About 3.3 million men diagnosed with prostate cancer at some point in their lives do not die of the disease. Prostate MRI has been used since the 1980s. Like you know, MRI has exuberant soft tissue contrast resolution. It's great when it comes to certain pathologies. And in the 1980s, we started looking at, well, we can see it well, can we see cancer as well? At the time, we started using T1 and T2 sequences, which were more of a just a morphology evaluation. These imaging studies are specifically for local regional staging in patients that already have biopsy-proven cancer. However, we still have a limitation between identifying those cases that have, or those patients that have a benign pathology and a non-clinically significant cancer, or low-grade cancer, from those patients that do have a clinically significant cancer. And we'll get to that in a minute. So this is a slide that shows just a little bit about the evolution of where we were in the 70s. We were trying to look at cancer in rats' prostates, 1971. And this is just one picture of the prostate in its coronal plane, right, going from anterior to posterior. Here we have the seminal vesicles. Here we have the beginning of the ejaculatory ducts, and this is the peripheral zone of the prostate. And I just want to illustrate going from something like this and like that to what we are today, like this. It's just beautiful, the depiction of the small detail. Now, nope, I press it. Okay, Okay. Now, is that enough? Just because we see it well, is that enough to diagnose cancer? It isn't. Advances in technology, both the software and the hardware, have led to today what we call multiparametric MRI. Multiparametric means that you have multiple parameters to see something and to identify something. For example, with CT, mostly is a morphologic assessment. You see it, you can measure it, you know if it's abnormal or not. With MRI, you can see the actual size, you can measure it, but you can also see the behavior of said pathology. Different types of cancer, for example, will behave differently depending on where they are and depending on the kind of cancer, the underlying histology of it. So we have T2, which is just another word for how our protons are being imaged. That sequence provides a good anatomic assessment, the size, the shape, where it is. And then we have the DWI or ADC map, which is diffusion weighted imaging, which provides a functional and a physiologic assessment of the actual tissue that we're looking at. And this particular sequence, the DWI, is one where there's a lot of research going on. Some of the other sequences have plateaued a bit because we know what they're showing us, this one, and also the contrast enhancement sequence. Currently with PIRATS, which is the bulk of my talk, a prostate imaging reporting and data system. It's a risk stratification system where you look at the prostate and you see how likely is that finding to be benign or not. It's pretty binary. So some of these sequences are less useful than others. The DWI is the one that it reigns supreme. Other benefits of this technology is, well, we have better detection of those cancers that are clinically significant, which is what we want to detect. And then on that note, we have a reduced mortality if we are able to detect these. The other area where there is most research is increasing our confidence in benign pathology and non-clinically significant cancer. So this is where we fall kind of short when it comes to diagnosing cancer. You want to reduce unnecessary biopsies and overtreatment. Okay. These are some of the indications for multiparametric MRI. Again, tumor detection, localization, and characterization. Most importantly is risk stratification and surveillance. We can assess suspected recurrence, but let's put a pin on that because not quite. But also we can guide image for biopsies, for surgery, and even for focal therapy. PIRADS, like I mentioned earlier, is prostate imaging reporting and data system. In radiology, there's a big push for trying to risk stratify oncology imaging. Where these stratification systems go from 1 through 5, and the one that is the most familiar to us is breast, BI-RADS, right? It's the one that started very many decades ago. It's a federal mandate today. That is the goal with all of our other RADS. We have RADS for everything. Well, liver, we have prostate, we have bladder, we have nodes, ENT cancer. So as we collect data, these documents, these systems evolve. One of the challenges that we have between these systems that involve more advanced imaging, like prostate with MRI versus breast with mammography, is that, well, breast in mammography is only an X-ray, and it's either yes or no. With prostate MRI, it's a very complex imaging technology with multiple variants, multiple vendors. So you start adding more complexity to it, and it becomes a little bit more challenging to standardize across a very large population. Okay. PIRADS has limitations. It is not a comprehensive document. It is not really designed currently to detect recurrence after treatment. It is underway. It's called PI-RR to detect recurrence. It is not intended for evaluation of the progression during surveillance. And it's also not intended to characterize parts that are involved with prostate cancer that are not the prostate. So it's not really a metastatic workup for bone or lymph nodes or extent of disease. It's a very focused examination. Some of the clinical considerations that we have when performing and scheduling this exam are the timing of the MRI after the patient's prostate biopsy, the patient preparation prior to getting on the table for the MRI, and of course the patient's information. The reason why this is so important versus perhaps with mammography, well, all you have to do is just make sure you don't have deodorant that day so it doesn't introduce artifact into your X-ray, is because of the intrinsic sensitivities of MRI. You know, if the patient moves, it completely degrades your imaging. If the patient doesn't have an adequate prep, there's a lot of rectal gas, it will interfere in your imaging. So now, again, like I said before, you have many different variables that were little by little start degrading your diagnostic performance. This is an example of a patient that had a prostate biopsy a couple of days prior to his study. So we will talk about anatomy in a second, but here, this whole thing is the prostate gland. This is the rectum. This triangle, white triangle here, this is fat. The bladder would be somewhere around here. This is another sequence. This is T1 before contrast. This is a fluid-sensitive sequence, and this is, again, ADC, one of our most important sequences. When you have blood in the peripheral zone, everything looks the way it should not look, and it can look similar to cancer. So this is certainly, oh, okay, so this is certainly a diagnostic challenge. Thank you. This is another very important slide. This is what motion does. You are not able to see the prostate that well, let alone the cancer, when the patient has rectal gas and has a lot of motion. Why do I keep doing that? There we go. After patient preparation, this is the same patient. You can see that there's no rectal gas, and now the prostate looks beautiful. You can see it really well, the anatomic detail. Again, antispasmodic agents will help with the resolution and the motion. Right? This is another beautiful depiction of the ejaculatory ducts on a patient that is well prepped. Some of the technical specifications are your magnet strength. We talk about 3 Ts and 1.5 magnet. The reality is that you are able to get really beautiful and crisp and images of high diagnostic yield in a 1.5 magnet, right? So we use the 1.5 on patients that have bilateral hip arthroplasties, for instance, or have other prosthetic implants that exclude them from having a higher field magnet. So this is just very briefly the anatomy, the peripheral zone. This is where prostate cancer occurs most frequently. About 75% of cases occur here. That's the area that we want to see the best because that's where we have most of our detection success. In the transition zone, it becomes that much difficult because of how heterogeneous it is. So this is another example of how homogeneous our signal looks and how great our anatomic detail is. And these are other examples of just how important our resolution is in MRI to detect this. So with PI-RADS, again, we're trying to detect that is clinically significant. So these are 4 pictures of T2 sequences. This is a normal prostate. This is a prostate that is not normal. It has a large cancer here in the transition zone. And these are 2 examples of prostates that do not have cancer but have really severe BPH, right? So this also decreases our sensitivity to detect those cancers in this area. Again, this is another patient that has a normal peripheral zone and has a little bit of signal abnormality here that looks like cancer. This is a normal transition zone, a normal peripheral zone, and this is a patient that is very heterogeneous with cancer. So notice that beautiful anatomic detail. And these are more examples. Thank you. These are more examples of benign entities, and we are able to detect these great with MRI. Before on ultrasound, we would just biopsy that because with ultrasound, it's very difficult to detect or to differentiate that from malignancy. Okay, so these are more examples of hemorrhage just obscuring your ability to detect the cancer. And these are some benign entities. We're also able to detect cystic lesions. This is not cancer. These are just different sequences. This is a cystic lesion, and this is the same cystic lesion on ultrasound. So we are able to detect and differentiate benign from malignant entities. Prostatitis is also something that we can detect on imaging, and this is a diagnosis of cancer. This has a benign finding elsewhere in the prostate, but here we have this little spot of abnormal signal. Well, is this prostatitis or is this cancer? This one ended up being granulomatous prostatitis. This is also prostatitis. Okay. So with our reporting, we go by Gleason score. That's the histology that the pathologist would provide us. And this is our PIRATS. So PIRATS means very low clinically significance and very high probability of having clinically significant cancer. And these are some of our prostates that have no cancer. And these are some of our prostates that have cancer. So you can detect this dark spot here, and these are biopsy-proven cancer. So time is up, I presume, right? Okay, 2 minutes. But I hope that with these really quick slides, I gave you a very simple overview of how we can see prostate cancer, whereas before we were using ultrasound to see the prostate. Now we're looking MRI to find the actual cancer.
Thank you very much for that talk. Do you have any, are there any questions from the audience? I know I have.
Yeah, so I have a question. Thanks. That was a very interesting talk, and especially as a man, you know. So, but I'm curious. All of the assessment, it seems, was based on just on regular morphology, right? There's no attempt to use contrast or dyes or anything else. Is that a future direction?
No. Well, yes and no. So
Okay.
Initially, similar to breast, we used contrast enhancement to characterize additionally, right, that lesion. Now we know that the way prostate adenocarcinoma behaves is that they can have all different varieties of enhancement kinetics, right? It can be washout, it can be plateau, or it cannot enhance at all. So that's why the contrast portion of the exam is really, fallen at a more of an ancillary feature. Right now, currently, some of our advances are ultra short biparametric MRI, not multi-parametric, where you see the T2, which is the morphology, and the DWI, and that's it, 2 sequences. So that's how I interpret my prostates, even though I acquire the whole thing. Just because on those patients that have, they move during the DWI sequence, I have other ancillary features, right, to kind of rely on. But our future direction is trying to fine-tune our specificity and trying to make our sensitivity not as good. That's where we're trying to go. Because right now you see something that looks abnormal, you put a biopsy on it, comes back Gleason 3+3 or non-clinically significant cancer. That was a discordant report. I said something was clinically significant when it wasn't. So that's where we are trying to get better, trying to let go of those that is catching your eye, but it's not really something suspicious.
Thank you very much.
Thank you.
Any other questions? I have one.
I have a question. John, I have a question.
Yes, please go ahead.
Although I wanted to be there, thank you for this very interesting presentation. Is this parametric MRI being used for the robotic surgical removal of the prostate, or how do they guide now the robot?
The prostate MRI is very helpful when you are directing treatment, for example, when you're doing a local therapy and let's say cryoablation. It's also very useful when you're doing the fusion biopsy. So what we do is we capture the lesion on the MRI sequence, that is the morphological sequence. And then we import that sequence to the urologist's workstation, which is under ultrasound. And then we fuse those two sequences, and the urologist is able to direct the needle to where the radiologist mapped that lesion. So that is where MRI really comes to play with directing the biopsies, right? So these are called fusion-guided biopsies. In terms of treatment, it's also very helpful with the radiation oncologists when they are trying to target where to put their catheters. As for the actual prostatectomy, that I have not really seen much, I mean, other than a structural abnormality, you want to see it first, how the prostate looks and what things you can encounter once you're there. But in terms of the actual procedure, not that I'm aware of.
Thank you. Thank you. Fascinating.